the session. And our first speaker is Zuhal Abasiyanik from Hasselt University in Belgium. She's right now in Turkey, but she's working in Belgium. Zuhal completed the master program in neurological physiotherapy and rehabilitation at Dokuz Anadolu University in Izmir, Turkey, and subsequently obtained her doctorate in physical therapy and rehabilitation. She is currently pursuing her second doctoral degree in the Rehabilitation Sciences program at Hasselt University in Belgium. And her primary research areas are focused on cognitive motor interference and fatigability in multiple sclerosis. Welcome, Zuhal, to our iWiMS meeting. I think you're muted, Zuhal.
Sorry. Thank you for this invitation and introduction. So I will just start presenting my presentation. Today, I'm going to present about our international work on psychometric properties of patient-reported outcome measures assessing dual task difficulties in MS patients. And this study funded by RIMS Research Grant Program. Sorry. And firstly, as we know, dual tasking is very relevant task for daily life because in daily life, we do not perform just pure motor task or pure cognitive task. We generally perform at least two tasks simultaneously, such as walking and talking, walking and texting, walking and calling someone, or eating something and doing our work. So to these activities, automatically, we need an intact motor function and intact sensory function and minimal cognitive resources. But in MS patients, they have motor impairment, they have sensory impairment, so there is more reliance on cognitive resources to do these activities. But at the same time, they suffer from cognitive deficits in different cognitive domains. Therefore, when they do at least two tasks simultaneously, there is decline in their performance, which is called as cognitive motor interference. And it has been reported as a different. Can you hear me now?
Yes, we can hear you.
And there are different magnitudes has been reported in literature because there are very heterogeneous methods in there, because they use different motor tasks and different cognitive tasks, and they are generally just one single motor task or single cognitive task. Therefore, there is inconclusive evidence about if MS patients show greater performance decline in dual tasking or if they have greater perceived dual task difficulties in their daily life. It is a very typical laboratory conditions from our lab, because in a lab, we generally perform walking task, balance task, or upper extremity task in a very standardized way. And they are free from external distractors or unexpected events that we always encounter in daily life. So we just see the upper part of iceberg. But patient-reported outcomes can identify our daily life conditions because they include many daily life scenarios that we cannot mimic in our laboratory conditions. They have also other benefits, such as they are practical, they are time saver, they are low cost, so they have high potential for diagnostic or therapeutic purposes. So for dual tasking, there are three existing questionnaires. First of them is DTQ. It has been developed for patients with stroke and traumatic brain injury. It is 10 items and items rated from 0 to 4. The second one is dual task screening list. It includes 13 items. It is a checklist, so items are, yes, I have a difficulty on that task, or I don't have a difficulty on that task. And it has been developed for patients with Parkinson's disease. The last one is DDAQ. It has been developed specifically for MS patients, and it includes 19 items. items are rated from 0 to 4. And in our systematic review, we documented their measurement properties, and we saw that there is need for more studies on reliability and construct validity of these questionnaires for specific populations. And there is no information about discriminative validity of all these questionnaires, which means that we don't know if MS patients have higher dual task difficulties in their daily life. Therefore, we designed an international multi-center study, including Turkey, Israel, Italy, Belgium, Spain, and Chile, and we enrolled 356 MS patients. Half of them were mildly disabled and half of them were moderate to severe disabled. And we also include 184 age and sex matched health controls. And we investigated psychometric properties on reliability and validity by following COSMIN guideline. And this guideline specifically designed for patient-reported outcomes. So we investigate internal consistency, test, retest, reliability, and measurement error for reliability. We also investigate construct validity of these questionnaires. So we use 3 dual task questionnaires that I mentioned before, and we also perform laboratory-based dual task assessment. Participants walk during 30 seconds with and without word generation task, and we calculated dual task cost, which means percentage change between single task performance and dual task performance. And we also use some descriptive measures, including STMT for cognitive processing speed, time to 25-foot walk test for fastest walking speed, 9-hole peg test for manual dexterity. We recorded their fall history in the last 6 months, and we also include some patient-reported outcomes for fear of falling, fatigue, and perceived walking disability. And as a result, what we saw, for internal consistency, it means that interrelatedness among items, and it is measured by Cronbach's alpha coefficient, and we expect higher than 0.7 for sufficient internal consistency. And as you see, all in total sample and in all subsamples show sufficient internal consistency. And when we see separately of these questionnaires, green bar shows DDQ, a yellow bar shows DTSL, and blue bar is DTQ. And DDQ showed highest internal consistency among these 3 questionnaires. For test, retest reliability, which shows the similarity between the score in 2 time points, and we expect a higher than 0.6 scores, and all questionnaires showed in all samples sufficient test, retest reliability, and the Q showed highest test, retest reliability among these 3 questionnaires. For the measurement error, we calculated the standard error of measurement and smallest detectable change, and we expect lower measurement error to say, yes, this questionnaire is reliable. And among these questionnaires, the DQ showed lowest measurement error. For the validity, we first investigate hypothesis testing, and we define some predefined hypotheses, and which means that a degree of confirmation of predefined hypothesis and correlation between dual task questionnaires and other clinical variables, and we measure it by Pearson or Spearman correlation coefficients. And as you see, questionnaires showed strong correlation with each other. It is not surprising because we hypothesized that they are measuring same construct, so we expect strong correlation between them, and it has been confirmed. And we expect low to moderate correlation between performance-based measurement for walking, upper extremity, and cognition and falls. And it has been confirmed by correlation analysis. There was a low to moderate correlation between questionnaires and these measures. And we found strong correlation with patient-reported outcomes for fear of falling, perceived walking disability, and fatigue with questionnaires. And when we see separately, the DQ showed highest correlation coefficients with other variables. For the structural validity, we performed factor analysis to define dimensionality of the questionnaires, and we found two factor structure for each questionnaires, and we labeled them as a cognitive-driven subscale and motor-driven subscale. For cognitive-driven subscale, items were generally include one motor function, such as walking or stairs, and one cognitive function, such as planning or thinking something. And for in motor-driven subscore, items are generally motor tasks, such as walking and carrying a cup, walking and drinking something. And in all subscale, there are at least 3 items in each subscales. Therefore, it shows suitability of this analysis. For the discriminative validity, we compared first the dual task cost between MS patients and healthy controls, and there was no significant difference between the groups, and the effect size was low for laboratory-based dual task assessment. But for the questionnaires, we found that MS patients always show higher dual task difficulties in dual task questionnaires. And for the effect size, it was a medium for DTQ, it was medium for DTSL, and it was large for DDQ. And we also confirmed this analysis by area under curve value calculation. It ranged from 0 to 4 and 0 to 1, and 1 show perfect discriminability, and the DQ showed highest discriminability among these 3 questionnaires, and the second one is DTSL, and the third one is DTQ, but they all showed good discriminative ability between MS patients and healthy controls. But dual task cost did not show discriminative ability. And we calculated cutoff values to define patients with dual task difficulties. And it was 45 for DTQ, it was 25 for DTSL, and it was 14 for DDQ. And based on these cutoff values, we also calculated prevalence of dual task difficulties. And it was around 4% in healthy controls. But in mildly disabled patients, it was from 25 to 45%. And in moderate to severe disabled group, it was almost 50% to 87%. So prevalence increased with disability. So as a take-home message, DTQ, DTSL, and DDQ have good to excellent measurement properties, so it can be used for future clinical trials or clinical practice, and DDQ showed higher measurement properties, and we also verified this analysis in subsample in different countries. And secondly, all questionnaires showed 2 main factors allocated as motor-driven subscale and cognitive-driven subscale. And thirdly, dual task cost is similar between MS patients and health controls, but MS patients show greater dual task difficulties in patient-reported outcomes. And all 3 questionnaires show good discriminative ability, and DDQ was the best for discriminability. For the prevalence, it was around 4% in healthy control. It was up to 45% in mildly disabled patients, and it was up to 87% in moderate to severe disabled patients. As a conclusion, the use of patient-reported outcomes can be promoted after this study for clinical practice or future clinical trials to understand patients' dual task difficulties in their daily life. So thank you very much again for this invitation and attention from the audience. And I would like to specifically thank this amazing research team for making this study possible. Thank you.
Thank you, Zuhal, very much for this amazing talk. As well, a reminder for everyone, if you have any questions for Zuhal, we'll have them together with the other questions to the next speaker at the end of the meeting. Thank you very much again. And now I'm thrilled to present our next speaker. She's Dr. Gloria Dalla Costa. She's a distinguished researcher and neurologist from San Raffaele University in Milan. Dr. Dalla Costa's expertise lies at the intersection of clinical neurology, biostatistics, and big data analytics, with a particular focus on MS and NMOSD. Dr. Dalla, Gloria, started in San Raffaele University, where she obtained her medical degree and subsequently completed her residency in neurology. Throughout her career, she has demonstrated commitment to MS research, and she has extensive involvement in over 20 national and international multi-center clinical trials in both MS and NMO. Driven by her passion for research and dedication to enhancing patient care, Dr. Dalla Costa pursued a further education, earning a Master of Science degrees in both biostatistics and big data analytics from Bioca University in Milan. And she is currently serving as a visiting scholar at Harvard School of Public Health in Boston, USA, and where she continues to expand her research horizon. Her primary research focus centers on exploring environmental risk factors associated with MS, identifying biomarkers, and uncovering prognostic factors in patients with clinically isolated syndromes and early MS. And so today, Dr. Dalla Costa will be sharing insights from her latest publication titled A Wearable Device Perspective on the Standard Definitions of Disability Progression in MS. And this is a result of a collaborative research program called Radar CNS, where I also collaborated. So that, please, Gloria, the field is yours.
Well, thank you, Anna, for the extensive introduction. That is the title of my presentation. So, a wearable device perspective on the standard definition of disability progression in MS. These are my disclosures, and here we are. So, wearable devices have a long story. They actually started with Leonardo da Vinci in the Middle Age, where it introduced the first kind of wearable device mainly for military purposes. Then wearable devices became, across the year, more and more diffuse, first for military purposes again, then for sport agonists, and then in more recent years to the general population. And since that, wearable devices started to be applied to medicine as well. And as you can see here, the portrait of typical wearable device user nowadays is that of a person of middle income, young to middle age, and of female sex. They use wearable devices mainly for self-improving, so to be active, to lose weight, to improve sleep, and so on. And as you can see, this portrait is also that typical of a person with multiple sclerosis. And multiple sclerosis, as we know, is a disease with many different features. It can involve fatigue, depression, problem to vision. It can involve disability in the movement or problems in dexterity, as well as, for example, dysautonomic problems as well to patients. And actually, we have so many sensors embedded into wearable devices that they are really able to capture all these different phases of multiple sclerosis. There have been previous studies showing that where a patient is walking comfortably, or is walking very fast, or is walking slow, Well, actually, wearable devices are pretty accurate in measuring how well a patient is walking, even if the patient is highly disabled. There have been other studies showing, for example, wearable devices are able to capture the quality of the sleep of patients, and other studies showing how wearable devices are critical for example, monitor the risk of falls of patients. In the study we carried out together with Anna and the Barcelona Center and the Copenhagen Center, we aimed to explore whether wearable devices were able to provide a more granular and objective measure of disability progression than standard definition of disability progression that we knew are somehow limited. And so here you can see the sensor we used was actually a Fitbit, so a really common wearable device. And that was used for passive monitoring, but we had in place also strategies for active monitoring. Particularly, we had 2 apps for that. And the study followed up patients, 400 MS patients, for up to 24 months with regular 3 monthly neurological clinical visits. So for our specific aim, we define disability progression by the EDSS with a standard definition that is an increase in 1 point when the baseline EDSS was lower than 5.5 or 0.5 if the entry score was above the threshold. And we define disability progression by the 6-minute walking test and time at 25-foot walk as a 20% worsening at the respective test. And in this study, to explore our aim, basically we use a longitudinal linear mixed effect model to model how this definition of disability progression behave with respect to what the wearable device is recording, that is the number of steps recorded by the Fitbit. Here you can see the baseline characteristics of our population, and you can see that these resemble the characteristic of a general MS population, that is 2/3 of patients were females. The median age was 45 years, and the vast majority of them had a relapsing remitting form of multiple sclerosis. EDSS at baseline was 3.5 as median, and the vast majority of patients were on disease-modifying drugs, and across the follow-up, a very small amount of patients had actually clinical or MRI activity. And here you can find the first results, that is how disability progression defined by the EDSS compared to what the Fitbit is recording. And you can see that at baseline, actually, there is a distinction between patients that later went on developing disability progression defined by the EDSS and this other patient, because, but actually, along the follow-up, the two groups behave similarly, that is, the lines are not crossing, and that is, both of them are actually getting worse and not significantly differently. We went on further exploring this, and we tried to understand whether there were specific features of patients misclassified as being stable by the EDSS, but it actually got worse according to the Fitbit. But yes, we could identify a class of patients that were really misdiagnosed by the EDSS, because actually they really got worse with according to the Fitbit. But actually, there were no characteristic features of these patients. And then we went on exploring this concept also for the other definition, that is with a 6-minute walking test, and how the disability progression defined by this test compare with what the Fitbit is recording. And again, here we saw a difference in baseline, as other studies shown, but actually looking at what happens in the follow-up, we can see that there is not a significantly different behavior in two groups. That is, either patients that were considered stable by the 6-minute walking test and those considered worsened according to this test actually got worse in a number of steps and got worse in a similar way. And it's also applied to the last definition of disability progression, that is the time 25-foot walk test. So to conclude, as in prior studies, we showed that there is a direct correlation between reduced walking activity and higher disability scores. But actually, the reduction in step counts does not align very well with changes in standard clinical scales, probably because the step counts is more sensible. Has more sensitivity to the real status of patients. So actually, wearable device really enhanced clinical trials and efficiency because they could identify patients at high risk of disability progression. So of course, study had a limitation, but if the study will be validated in further studies, this could be really of importance because, of course, they show that wearable device is really critical for obtaining a more, for improving the management of MS patients and for a more personalized approach to the management. So, and that is my conclusion. So thank you very much to all of you for listening, and above all to the committee for inviting me to present our study here.
Thank you, Gloria, for interesting talk. Well, now you can give your questions to both Gloria and Zuhal. I see that there's one that Emmanuel has asked one question in the chat. I don't know if you want to ask it yourself.
Sure. I mean, great talks, the two of you. So I feel very happy to see so much collaboration, and hopefully iWiMS has helped the collaboration to develop. So I almost feel I can retire now. So let me go back to my questions. So the questions I had written in the chat was for the first talk. And so it was a little surprising to me that there was no difference between the controls and the MS patients in terms of their performance on the dual task itself. So how do you explain that? Is it because maybe there was not enough sample size, or I don't remember the sample size, or whether the dual task was too short, or the MS patients were with a low EDSS?
Thank you for this question. It is a very good question, and we are discussing a lot of this result. And I think that there are multiple factors can affect dual task performance in laboratory conditions. Compared to other studies, we have a good sample size, more than 300 patients and almost 200 health controls. So to exactly respond to this question, we need to know determinants of dual task cost. So there is no information in literature about determinants. It can be related to the task that we used, because the cognitive task a bit easy compared to other studies. And we know that in dual task studies, if cognitive task is more difficult, the cognitive motor interference is higher. So more difficult tasks can catch this difference between dual task cost, different groups. And also duration of the test can affect this result, because we use just 30 seconds and it can be more automated in these short durations. And after after, for example, 1 minute, we could see differences between the groups more. And in some studies, if they use 1 minute or 2 minutes for dual tasking, there are significant difference between the two groups. So it can be related to task duration and other clinical factors that we don't know yet. So we need some studies on determinants of dual taskers in different disability levels.
And so do you, I know it was not the topic of the presentation, but the next question is, you know, if we want to use that, for example, in clinical trials, do you have data, or have you been able to start looking at longitudinally how maybe MS patients are not stable over time, even with 30-second duration of the dual task compared to controls, or maybe you're not there yet?
No, we just did cross-sectional design, so we don't know longitudinal results yet. So it is our recommendation for future trials to follow patients in longer periods to see this change between time periods.
Thank you.
You're welcome. Thank you for your question.
Thank you very much for your question and for your answer. I have another question regarding you said that dual task patients with MS, with mild MS, had up to 50% for dual task. Would you, well, and we would consider calling them mild MS? And I find it quite high. And is it related with cognition?
I cannot hear you very well, but if I understood, did you mean that since mild MS patients show at least 0.5% of them show dual task difficulties in their daily life, do they need intervention for feature or?
No, I meant, well, I don't know exactly what was the definition of mild MS, but consider what I wouldn't say that that's a mild MS if they're not able to pursue, if there's such a difference with healthy controls, if they're not able to pursue this task up to 50% of them.
Yeah, the definition was from 0 to 3.5 EDSS for mild disabled, and from 4 to 6.5 for moderate to severe disabled MS. It's a bit conflicting in literature about disability classification, how we can classify as a mild or moderate. So we decide based on some studies and opinions of neurologists. So they have mild motor disability in between from 0 to 3.5, and then 4 to 6.5. So we also did exploratory analysis. If in the very mild disabled patients show difference between healthy controls, in EDSS 0, they show difference between healthy controls. In EDSS 1, they also showed, so it increased a bit with disability.
Okay, thank you very much. I think we lost that. So I'll continue with Gloria. When I think when we started the radio series,
Anna?
yes, I think we had
I think we're now
technical
back.
problem. Okay.
Yes, I'm sorry.
No, it's
I
fine.
think my internet collapsed, but I think we're back again. Yes.
I actually was thinking that it was weird that you could disappear from the call and not all the call, and then everything went down. I was asking Gloria that when we started the Radar CNS, I think we were very optimistic on what wearables device could add to the definition of mass or progression, and this to the silent progression and so on. But I think that from what we found, a lot of technical problems and challenges. I don't know. I would like to ask you about how do you feel right now about what are the main challenges that we have to face to implement this, to use it in clinical trials, from the first thing, and afterwards in daily basis in a clinical visits and to do clinical decisions.
Well, yes, as you want to know, we had first of all a compliance problem, particularly for the active part of the study. That is, patients are really excited in the beginning, but then the excitement goes away, and if you keep asking questions month after month, they get tired of this. So for active, I think we have to distinguish between those feature of the disease that we can monitor through active and through passive monitoring. So through active, we saw mainly this problem. And through passive, we saw one of the main problems was that, well, actually the Fitbit itself was very well accepted by patients. But for example, if you use other type of sensors, such as, for example, a sensor that you wear on your body, such as we use in that instance of virus, but there are now many trials using, for example, activity or devices that you really attach to your skin. Well, actually, patients do not perceive that very well because somehow they start to have itch or to have discomfort because of that. And the other problem we saw was that devices that relied on a connection to the smartphone were really a burden to the battery of the telephone and to the smartphone. A patient care very much about their smartphone, even somehow more to they understand. I mean, more that the smartphone is off than if they keep it up, they can improve their monitoring of the disease. So yes, these were the problem we faced. But actually, there were other problems because the amount of data we collected was really huge. So, and this was for a limited sample of patients and for a limited time frame. So we really had to have in place a work package dedicated to all this, to store data, to check that things were going on pretty well, even with above all with passive data that were so huge to handle. And so I think this is the main technical problems we can see in the application of these technologies to clinical trials and above all to everyday clinical practice. Well, a clinical trial, again, it's a limited population with a limited time frame, and so I think those are applicable somehow to clinical trials, taking from the expertise of our trials and of other similar trials. So mainly they could focus on wearable devices that are shown to be well tolerated and somehow recording reliable data from patients. For clinical practice, I think we are a little bit behind because I don't see in the near future a way we can overcome this. So, I mean, to overcome this limitation, that is the amount of data to be collected by the single patient, then for clinical practice, yes, I think we are still distant from that, but at least in clinical trials, I think wearable devices could be ready to, above all for progressive MS, where we are limited by our clinical schedule, really limited in capturing what patients are telling us. Wearable devices can be.
Thank you,
Thank you
Gloria.
so much, Gloria. I think you made a very interesting point that with the two presentations, we are asking to this data, will they be useful for clinical trials, for the big data analysis? But I think both information can be really helpful in the clinical practice today. I'm used to ask my patients, for instance, I use the Google Maps for recording their exact meters that they can walk without assistance. I think I used it like for 10 years ago, so I can record the exact number of meters that they can walk between one clinical session to the other. And to all the patients, for instance, I have a Fitbit from, I think, 2012. So I'm a 10-year Fitbit user, and many patients have their step counters in their phone or in the Apple Watch or in their integrated phones, and I use them with both purposes. One is to measure the number of steps they are making a day, and two, to make the goal for them to walk like 500 steps more or 1,000 steps more, especially for patients that cannot go to the gym or have a very active job, and they feel that they cannot make any more exercise beside walking. So I think we can use the devices right now. And for instance, with the dual task test, the PRO that Zuhal presented us, I think that we need to address what are the determinants. I was a healthy control of the trial, and I was wondering myself if that night I slept well or not, if I was burned out or not, if I was with anxiety for something or with the stress for something. So we need to move forward with the determinants of these, for instance, dual task performance changes, so we can measure this in our clinical practice and make some recommendations. So I feel that with this big data, we can make clinical practice changes like every day. But of course, we need to understand them more, and all this collaboration, as Emmanuel commented, are able to explore these new data sets from a larger point of view. These are all multicentric trials with a huge amount of patients. So I congratulate you both for the presentations. That's my comments.
Thank you.
Okay, I don't know if anyone wants to share an experience with wearables, PROs, anything about the talks.
I want to share a comment on Zuhal presentation. Hi Zuhal, it was very nice. And I was thinking about that dual task cost that in the laboratory based setting it was not showing a difference between MS patient, people with MS and healthy controls. And I was reflecting that actually in daily life, when we are doing dual task, we are prioritizing both of the tasks. So we cannot fail either one or the other. While in the laboratory setting, many times you may have, yes, you may have to continue the motor task, plus you have this dual task, but is not that you are that your focus has to go both way, and maybe the second task can help you in the motor task as well. I was thinking, what do you think?
Yeah, that's true. We did not give an instruction about prioritization, so we just say do most tasks at the best levels, so don't prioritize any of them, but maybe they did, we don't know yet. So for the last sentence, I agree with some patients. They say, if I have a high fear of falling, when I think something, I forget about my fear of falling and I walk better. So I heard some very disabled patients this kind of feedback. So we don't know it. Maybe they walk better when they not focus their walk a lot, because for very disabled patients, they focused a lot for their walking quality, their walking speed. But when we give another task, they prioritize this cognitive task, and then walking is better. So it would be, but we don't know yet.
Thank you very much, Zuhal, and well, I don't know your name, but for your question. Does anyone have any other comment or question? If not, I think we can wrap up now this meeting. Thank you very much to both of you. Was very, very interesting. We have an Emmanuel. I don't know. Okay. Very nice.
It's nice. It's nice sometimes to see everybody's face. So that's why I turn on my camera for the end.
Thank you very much. I also agree on that. Well, it was great to have you, as Emmanuel or Ethel said. It's great to have international studies, shared studies. I think this is one of the things that iWiMS promotes, and we're happy to have you here to present your results. And in that sense, we invite any one of you that wants to present their study, or has a fellow or a colleague that you think it's suitable for the presentation here, we invite you all, and we're more than happy to have anyone who's interested to present here. And well, we have our next meeting will be held on Monday, May 27th. We'll share some some updates on that. And that also, if you want to be in the mailing list, or you know someone that wants to be in the mailing list, please send us an email. And thank you very much to the speakers. Thank you very much to all for connecting. We know that these hours can be challenging for some of you, but it's always great to have such an international ground here to share experiences and studies.
Thank you,
everyone.
Thank you.
Congrats. Bye-bye.
Thank you very much.
Bye-bye.
Bye.
Bye.